Hello friends, this is our continuation series of the ST segment derivation MI, which is part 3. In this, we are going to discuss about the antiplatelet and antithrombotic therapy. So first one is aspirin and P2Y12 inhibitor. For patient with the STEMI, aspirin decreases the reocclusion and reinfarction rate by nearly 50% and mortality by approximately 25%. The benefit of aspirin are comparable to those of the fibrinolytic therapy, and when used together, aspirin and fibrinolytic therapy provide additive benefits. So aspirin should be initiated at oral dose of 162 to 325 mg at the time the patient is first encountered by the medical person in the field or emergency department. Following MI, the lifelong therapy with the aspirin is indicated to prevent recurrent cardiac events. So efficacy appears to be similar at all doses greater than 75 mg, where bleeding risk clearly increases with the high aspirin dose. For example, adaptable trial demonstrated no significant difference in cardiovascular event between atherosclerotic cardiovascular disease patient assigned to 81 mg and those assigned to 325 mg of aspirin daily. Following initial high dose, that is 162 to 325 mg administered acutely in STEMI, the author strongly favored 81 mg of aspirin over high dosage for long-term secondary prevention for all patients with STEMI. In addition to aspirin, secondary antiplatelet agent should be added for acute management and secondary prevention in patients with STEMI. In particular, a series of trials established the benefit of inhibiting binding of ADP to P2Y12 receptor on platelet receptor, thereby decreasing platelet aggregation and activation. So clopidogrel is the thienopyridine derivative, that is P2Y12 inhibitor. The clopidogrel as an adjunct reperfusion therapy in thrombolysis in myocardial infarction. That is Clarity TIMI trial compared clopidogrel of 300 mg loading dose followed by 75 mg per day with placebo in 3,491 patients with STEMI who were treated with standard pharmacological reperfusion including fibrinolytic therapy, aspirin, and heparin. So, primary composite endpoints of death, MI, and occluded infarct-related artery assessed at the time of protocol-mandated angiography, and it was reduced from 21.7% in placebo arm to 15% in clopidogrel. At 30 days, the clinical outcome of death, MI, and urgent revascularization was reduced by 20%. The much larger clopidogrel and the metoprolol in myocardial infarction trial, that is COMET trial, was performed in more than 45,000 patients in China and was designed to evaluate the impact of adjunctive clopidogrel that is administered at 75 mg per day without loading dose on death and the major clinical event. So clopidogrel reduces the death, reinfarction, and stroke by 9% and death alone by 7%, both of which were statistically significant. Based on the result of these two trials, clopidogrel should routinely be added to standard fibrinolytic regimen in patients younger than 75. For patients undergoing primary PCI, similarly, an oral P2Y12 in a receptor antagonist should be administered in addition to aspirin. A loading dose followed by minimum of 12 months of maintenance therapy is recommended for patients with STEMI receiving stent. Presently available alternative including clopidogrel, prasugrel, and ticagrelor. If clopidogrel is used, the loading dose of 600 mg is preferred and should be given as early as before and at the time of PCI. In current and the OASIS 7 trial, compared high dose that is 600 mg loading dose followed by 150 mg for 7 days and then 75 mg for a day with standard dose, that is 300 mg loading dose then 75 mg of clopidogrel. The higher dose of clopidogrel strategy was associated with lower rate of cardiovascular death, MI, and stroke at 30 days and the lower rate of stent thrombosis among subgroups with the stent. The higher dose clopidogrel regimen was also associated with higher risk of the major bleeding. So next is the prasugrel. Prasugrel is the second generation thienopyridine that is more rapidly acting, more potent, and is associated with less response variability than the clopidogrel. The trial to assess improvement in therapeutic outcome by optimizing platelet inhibition with prasugrel thrombolysis in myocardial infarction, that is Triton-TIMI trial, enrolled this 13,608 patients with ACS who were scheduled to undergo PC. So patients were randomized to prasugrel 60 mg of loading dose, then 10 mg per day, and clopidogrel, that is 300 mg of loading dose, then 75 mg per day. Both drugs were initiated at the time of PCI with no pretreatment given. In subgroup of the patient with STEMI, the primary efficacy endpoint of cardiovascular death, MI, and stroke at median of 14.5 months was reduced from 12.4% in clopidogrel arm to 10% in prasugrel. Stent thrombosis occurred in 2.8% STEMI patient randomized to clopidogrel versus 1.6 patient randomized to prasugrel. So the prasugrel was associated with the net harm among patients with the prior stroke and transient ischemic attack, largely caused by excess acid, and is contraindicated in such a patient. In addition, there were two important subgroups in whom prasugrel was associated with excessive bleeding that nullified the clinical benefit, including more than 75 years of age and those. Ticagrelor is directly acting and reversible non-theodine oral P2Y12 antagonist. This agent provides the more rapid onset of action and more potent and predictable antiplatelet response than clopidogrel. It does not require activation by cytochrome P450 system. In study of the platelet inhibition in the patient outcome, that is plateau trial, ticagrelor was given in the loading dose of 180 mg, then 90 mg twice daily, and was compared with the clopidogrel, that is 300 to 600 mg loading dose and 75 mg daily, in 18,624 patients with ECS, and 38% of whom have STEMI. So at the end 12-month follow-up period, the primary endpoint of cardiovascular death, MI, and stroke occur in 11.7% of subjects in clopidogrel arm versus 9.8% in ticagrelor. So the risk reduction was similar in the STEMI subgroup. Similar to the finding in the current and the OSS7 and the Triton TIMI trial, stent thrombosis was reduced significantly with more potent oral antiplatelet regimen. Also consistent with the prior study, ticagrelor increases non-CABG major bleeding. Notably, in the plateau trial, the treatment with the ticagrelor resulted in significant 21% relative risk reduction in vascular mortality and 22% total mortality. The mortality reduction was unique to plateau group among trials with the P2Y12 antagonist. Ticagrelor has a side effect that are likely mediated by increases in the circulating adenosine. Dyspnea occurs in 10% to 15% of patients early after treatment initiation and is not associated with heart failure and is usually transient. Ventricular pauses may be triggered by ticagrelor early after treatment initiation, but this pauses also decreases in frequency over time and is rarely symptomatic and have not required an excess clinical intervention. Because of this side effect, the clinical should be aware of the history of reactive airway disease and significant ECG conduction abnormality when considering ticagrelor. The onset of action of oral P2Y12 inhibitor may be delayed among patients with the STEMI, possibly owing to the reduced gut perfusion that is common uh, early after presentation. So morphine administration also appear to reduce absorption of the P2Y12 inhibitor and contribute to delay onset of action. Nevertheless, the early pre-hospital administration of P2Y12 inhibitor has not been shown to improve outcome versus administration at the time of angiography for STEMI. Canagrelor is the intravenous fast-acting reversible P2Y12 inhibitor that may offer alternative strategy for patient to achieve rapid P2Y12 inhibition. However, the available data are limited to comparisons with clopidogrel and do not provide strong support for favorable risk-benefit profile of this drug in STEMI. Given the high dose at present time, we generally limit canagrelor use to patients unable to take oral P2Y12 inhibitors. Now, the next class of the drug is the glycoprotein 2B3A inhibitor. Although the use of glycoprotein 2B3A inhibitor in elective PCI has been decreasing, this agent remains adjunct to primary PCI for same patient in STEMI with heparin when heparin is anticoagulant use. Data are very limited in the current era of more potent and rapidly acting P2Y12 inhibitors. So current ACC/AHA guidelines recommended the use of glycoprotein 2B3 inhibitor at the time of primary PCI for selected patients who are receiving unfractionated weight heparin. Now regarding antithrombin strategy for patient receiving fibrinolytic therapy. The AHN-ACC guideline recommended the administration of anticoagulant as an adjunct therapy for all patients receiving pharmacological reperfusion therapy with fibrin-specific agent, that is alteplase, reteplase, and tenecteplase. For unfractionated weight heparin, the recommended dosing is 60 units per kg bolus plus initial infusion of 12 units per kg per hour. So the maximum dose is 4,000 with bolus, and with infusion it was 1,000 unit per hour for up to 48 hours. Low molecular weight heparin represents the attractive alternative to unfractionated weight heparin for patients receiving fibrinolytic therapy. In the enoxaparin and thrombolysis reperfusion for acute myocardial infarction treatment, thrombolysis in myocardial infarction, that is extract TRIMI trial, which randomized 20,506 patients treated with fibrinolytic therapy to intravenous unfractionated weight heparin for 48 hours or enoxaparin through hospital discharge. The primary endpoint of death and reinfarction was reduced from 12% in unfractionated weight arm to 9.9% in enoxaparin. Major bleeding occurred in 1.4% in unfractionated heparin patient versus 2.1% of those treated with enoxaparin, but there was no significant difference in ICH, and the net clinical benefit favored enoxaparin. The direct antithrombin agent have also been extensively studied as an adjunct to fibrinolytic therapy, but appear to offer no significant advantage over unfractionated weight heparin. Thus, of the currently available antithrombin agent, the low molecular weight heparin administered for the duration of hospitalization has been shown to superior to short-term unfractionated weight heparin and represents the most attractive strategy for patient managed with fibrinolytics. Now, antithrombin versus adjunct to primary PC. Intravenous unfractionated weight heparin with or without glycoprotein 2B3A receptor antagonist are titrated to appropriately activated clotting time has been cornerstone adjunctive therapy for patients with STEMI undergoing primary PC. Multiple studies have compared bivalirudin, that is a direct acting antithrombin, and alternative to unfractionated weight heparin in this setting. The harmonizing outcome with revascularization and stent in the acute myocardial infarction trial, total 86,000 total this 8,63,602 patients undergoing primary PCF STEMI were randomized to standard care with heparin plus glycoprotein 2B3 inhibitor to bivalirudin alone. The primary outcome, which was composite of efficacy and safety endpoint at 30 days, was significantly lower in bivalirudin plus versus heparin glycoprotein 2B3A inhibitor. This is known as Horizon's AMI trial. This was mediated by lower rate of major bleeding with bivalirudin and similar rate of ischemic outcome. Total mortality and cardiac mortality trended lower in bivalirudin arm. The issue of concern was increased risk of stent thrombosis within first 24 hours in bivalirudin group. Subsequent studies confirmed the lower rate of bleeding but higher rate of stent thrombosis with bivalirudin compared with unfractionated weight heparin plus glycoprotein 2B3A inhibitor therapy and did not substantiate the reduction in all-cause mortality. The meta-analysis, including 16 randomized control trial comparing bivalirudin with heparin, found that bivalirudin use was associated with increased risk of MI and stent thrombosis, but a decreased risk of bleeding and magnitude of the bleeding reduction dependent on concomitant glycoprotein 2B3A use. Oral anticoagulant. In the era of dual antiplatelet therapy, the use of warfarin and the non-vitamin K oral antagonist, either alone or in combination of DAPT, must be weighted carefully. However, because warfarin and the non-oral anticoagulation are superior to aspirin for preventing systemic emboli Among patients with atrial fibrillation, warfarin reduces systemic emboli in patients with documented left ventricular dysfunction following MI. However, some circumstances warranting consideration of oral anticoagulant therapy, particularly when the risk of thromboembolism exceeds the risk of bleeding. Current ACC and AHA guidelines support the warfarin use in addition to DAPT for patients who have mechanical heart valve, current recent venous thromboembolism, hypercoagulable disorder, and warfarin or NOVAC for atrial fibrillation with elevated stroke risk. Warfarin use is also reasonable for STEMI patient with symptomatic LV mural thrombi and perhaps for some STEMI patient with anterior apical kinesis. For patients with the risk of LV thrombus, the duration of warfarin use can be limited to 3 months. It should be noted that the newer direct oral anticoagulant have not been evaluated in this clinical context, so their use cannot be recommended. A challenging scenario related to the combination of aspirin, P2Y12 inhibitor, warfarin, and NOVAC, such as apixaban, rivaroxaban, dabigatran, or endoxifen. Approximately 10% of patients with recent PCI have concomitant atrial fibrillation. Triple therapy with warfarin has been associated with as much as 50% increase in bleeding compared to DAPT alone. Therefore, the withdrawal of aspirin component of triple therapy has been explored in order to determine the optimal balance between antithrombotic, antiplatelet, and bleeding. So the multiple trials have now supported the safety of dual pathway approach with NOVAC and P2 by 12 inhibitor. The network analysis of 4 clinical trials demonstrated that compared with the triple therapy, NOVAC plus P2Y12 inhibitor offer best safety profile for major bleeding and no difference in major adverse cardiac event. So taken together, these results supports the use of NOAC plus P2Y12 inhibitor as a preferred regimen after short period of triple therapy after PCI for high-risk patients with atrial fibrillation. However, given the relatively few data available among patients with STEMI, we recommended direct collaboration with the interventional cardiologist who perform the procedure in determining individualized antithrombotic regimen after primary PCI for patients who have induction for oral anticoagulation therapy. Ongoing research effort continue to search for optimal risk and benefit profile in this complex patient population. Now the next is anti-ischemic therapy. So beta blocker were among the first therapeutic intervention used to limit the size of acute MI. So previous trial that excluded the patient with heart failure, hypotension, and bradycardia demonstrated that very early administration of beta blocker decreases the infarct size and prevents the recurrent MI and death. The fact that beta blocker were particularly effective in reducing sudden death and reducing mortality among patients with the complex ventricular ectopy and baseline suggests that beta blocker exert much of this beneficial effect by reducing frequency and severity of arrhythmia. In addition, they appear to significantly decrease the risk of cardiac rupture. Data from the COMET trial in more than 45,000 patients, however, failed to demonstrate benefit from strategies of immediate intravenous metoprolol followed by 200 mg metoprolol daily or in hospital outcome, including death and myocardial infarction. Although early beta blockage reduces the risk of reinfarction and ventricular fibrillation compared to placebo, this was counterbalanced by increased risk of cardiogenic shock during first few days after admission. Post hoc analysis indicate that this increased risk was predominantly among patients with indicators of or risk factors for hemodynamic compromise. In addition, the outcome may have been influenced by a high dose of metoprolol used in the study. ACC and AHA guideline now recommended that beta blocker be initiated orally within the first 24 hours once it has been determined that hemodynamic status is stable and there is no evidence of heart failure. The parenteral beta blocker should be used only if there is clear indication, such as ongoing chest pain or atrial tachyarrhythmias with normal or elevated blood pressure. When given long term following MI, beta blocker significantly reduces the incidence of non-fatal reinfarction and mortality, an effect that extend to most members of this class of the agent. Carvedilol post-infarct survival control in LV dysfunction, that is Capricorn trial, examine the increment effect of the beta blockage to angiotensin converting enzyme inhibition in post-MI in patient with LV dysfunction but no clinical heart failure. Over mean follow-up of 1.3 years, the composite of death and MI reduced from 20% in placebo arm to 14% in carvedilol arm and 29% relative reduction. On the basis of robust clinical data and much favorable cost to benefit ratio, long-term oral beta blockade should be continued for at least 3 years in patients without heart failure following MI. Now, regarding renin-angiotensin-aldosterone system inhibitor. AC inhibitors are routinely used following STEMI to prevent the adverse LV chamber remodeling, gradual process by which left ventricular assumes more globular shape and dilates. Remodeling is associated with increased risk of heart failure and death. A large overview of almost 1 lakh patients found 7% reduction of 30% mortality when AC inhibitors were given to all patients with acute MI and with most of the benefit observed in the first week. The benefit was greatest in high-risk groups such as those with the KILIP class 2 and 3 and with LV dysfunction and those with anterior wall MI. In addition to preventing remodeling and heart failure, AC inhibitors prevent the recurrent major cardiovascular event after MI. As opposed to aspirin and reperfusion therapy, it is not crucial to introduce AC inhibitor in hyperacute phase of acute MI. Angiotensin receptor blocker are effective alternative to AC inhibitor for patients with LV dysfunction and heart failure following acute MI and provide similar long-term benefit. However, combination therapy with AC inhibitor and ARB is not more effective. Because of the large evidence base and the lower cost of AC inhibitor, they are preferred over ARB unless side effect to AC inhibitor develop. Aldosterone antagonist should be considered for use in appropriate high-risk patients following STEMI who are receiving adequate dose of the AC inhibitor. In the eplerenone post-acute myocardial infarction and heart failure efficacy and survival, that is FSS trial, which included patients with LV ejection fraction of less than 40% following MI and heart failure symptom and diabetes. Eplerenone treatment is associated with 15% reduction in risk of mortality. Because of its much lower cost, spironolactone may be considered as an alternative to eplerenone. Aldosterone antagonists should be avoided for patients with hyperkalemia and significant renal dysfunction. Despite strong evidence and the class 1 recommendation, in contrast to other post-MI recommendation, aldosterone antagonists remain dramatically underutilized in practice. So this is the data from EPTHAS trial showed that eplerenone treatment was associated with 15% reduction of the risk of mortality for among ST elevation myocardial infarction with the left ventricular ejection fraction less than 40% following myocardial infarction, either heart failure symptoms and diabetes. Regarding nitrate, nitrate dilates the large coronary artery and arteriole, peripheral veins, and to lesser extent peripheral arteries. So venodilation decreases the preload, but reducing the both myocardial oxygen demand and symptom of pulmonary congestion that may complicate MI. These trials collectively enrolled, that is GISSI and ISIS trial collectively enroll approximately 80,000 patients with evaluated long-term nitrate, that is 4 to 6 weeks therapy post. Neither study found a significant reduction in mortality with nitrate, although ability to detect such a difference may have been reduced because more than 50% of patients received off protocol nitrate. Although evidence from randomized clinical trials does not support the routine long-term nitrate therapy for patients with uncomplicated MI, it is reasonable to give intravenous nitroglycerin for first 24 to 48 hours in patients with acute MI and who have heart failure, recurrent ischemia, and hypertension. Intravenous therapy is preferred in early phase of MI because of its immediate onset of action and ease of titration. Nitrate should be avoided in patients with right ventricular infarction. Now, regarding calcium channel blocker blocks the entry of calcium via voltage sensitive calcium channel. In vascular smooth muscle, this causes coronary and peripheral vasodilation, where in cardiac tissue it leads to the depression of myocardial contractility, sinus rate, and AV nodal conduction. Dihydropyridine calcium channel antagonist, of which nifedipine is prototype, causes coronary peripheral artery dilation without blocking sinus and AV nodal function. As a result, any potential benefit of this agent is counterbalanced by reflex tachycardia. The short-acting preparation of nifedipine in particular appears too dangerous in setting of acute MI because they cause a rapid hemodynamic fluctuation. Sustained release preparation of nifedipine, on the other hand, can be used safely in combination with beta blocker. Amlodipine is the third generation agent that causes less reflex tachycardia than other dihydropyridine, but with other calcium channel blocker, there is no documented benefit of this agent following MI. Diltiazem and verapamil slows the heart rate, modestly reduce the myocardial contractility, and decreasing myocardial oxygen demand. A pool analysis indicated that verapamil and diltiazem had no effect on mortality following acute MI, but that they did significantly reduce the rate of reinfection. These agents decrease the mortality of patients with LV dysfunction and evidence of heart failure. There have not been studies the comparing the efficacy of verapamil and diltiazem to that of the beta blocker in patients with STEM. Because beta blocker consistently reduce both mortality, reinfarction, and calcium channel blocker should only be used in patients who remain hypertensive after full dose of beta blockage and ACE inhibition. Verapamil and diltiazem may be reasonable alternative for patients who cannot tolerate beta blocker, provided LV function is normal, but they should not be given routinely following MI. Now, regarding supplemental oxygen, in randomized trial comparing oxygen with no supplemental oxygen in 441 patients with STEMI but without hypoxemia, supplemental O2 showed trend towards increased early myocardial injury compared with control measured with cardiac troponin and increased infarct signs by cardiovascular magnetic resonance imaging. In view of the data, O2 therapy can be omitted if patient is not hypoxemic. On the other hand, patient with STEMI and arterial hypoxemia should receive O2. Thank you guys.